Thank you for the opportunity to share some of the advancements that have occurred over the last several years, specifically around what we call MARS, or MRI-Assisted Radiosurgery. I'll be speaking today specifically on some of our data from the management of high-risk and recurrent prostate with salvage and proton therapy in combination with MRI-assisted radiosurgery. Here are my disclosures, and nothing that I will discuss will include any non-FDA approved investigational product in my presentation. I'd like to start here because we're going to have a conversation at the VA later during the meeting, but this was a sentinel moment in the management of prostate cancer with brachytherapy. This was a investigation that occurred by Congress back in 2009 due to the Philadelphia VA, and at the time, we had a lot of veterans that were getting access to interstitial implants with radioactive seeds, known as brachytherapy. And there were a number of bad complications that arose that warranted and then manifested in congressional investigation. From that, there were a number of recommendations made, and essentially, because of the poor quality assurance within the VA hospitals, brachytherapy within the veteran administrations shut down. And currently, this is a technology, a single outpatient curative procedure that veterans do not have access to in the veteran administration, in the VA hospitals. And this is just a little representation of some of that poor quality assurance, and primarily because this is ultrasound and CT based initially. And what I mean by that is you can see here at the prostate base, midgland, and apex, you can see from ultrasound and CT, the seeds can be visualized. However, the anatomical information is lost. And because that anatomical information is lost, recognizing high quality or poor quality becomes much more complicated, especially at the apex. And if we look at the bottom panel, which is MRI, the soft tissue information can be seen beautifully, including the external urethral sphincter, but those anatomical data points cannot be seen under CT and ultrasound well. And you can see right here, this is millimeters away from the anterior wall of the rectum. And this external urethral sphincter, if it's implanted and is viewed as prostate on ultrasound, it can lead to strictures, and it can also lead to complications for patients down the road. So imaging with MRI is critical. The biggest problem with the imaging is you can't identify the seeds clearly to be able to understand what you've done with post-implant assessment. Therefore, many have been utilizing MRI fused with CT, but many times patients have different rectal filling, bladder filling, and those co-image registrations are not optimal and somewhat suboptimal. Here is the external urethral sphincter. I think this is a structure that has become much more characterized as a 1 centimeter diameter structure at the apex of the prostate. Clearly, all the surgeons are very familiar with this structure. Radiation oncologists are somewhat familiar, I think becoming more familiar, especially in the MRI space, right between the heads of the puborectalis muscle. And we now have a specific volume in which 200% of the prescribed dose can get access to this that will help minimize the risk of complications. And if you look from the external urethral sphincter to the anterior wall of the rectum, that is roughly 2 to 3 millimeters. So if you get this wrong and you over-implant the apex and get an ulcer on the anterior wall, that can result in a biopsy, an inappropriate biopsy can result in a fistula that requires a colostomy to repair. Major complication shouldn't happen, but now that we've got access to MRI, this can help our quality assurance. I call this now the no-fly zone. This prompted the finding what we call a C4 marker, which is a MRI-positive contrast marker that we developed at MD Anderson that allows for us to be able to localize and visualize the seeds for post-implant quality assessment. That was done both in a ex vivo canine prostate to evaluate and place between the titanium seeds. And then we did extensive studies looking at biodistribution toxicities of the cobalt dichloride and acetylcysteine, which we tagged, and that allowed for the technology to be then utilized in clinical care today. The other piece that I think that's really critical is we think about what we call MARS, or MRI-assisted radiosurgery, and radiosurgery is not an uncommon vernacular in the external beam language. We talk about radiosurgery all the time, especially with Gamma Knife and others. We talk about with stereotactic radiosurgical ablation in the spine. And the goal ultimately is to achieve a dose that is ablative. And the biochemical definition of cure, this is a 15,000 patient series that we published on a few years ago. This was specifically with 15,000 patients from Australia, Ireland, the BC, Toronto, and the United States. And what we came up with was a biochemical definition of cure that we can utilize following brachytherapy that's consistent with the surgical definition of cure. And that is 0.2 nanograms per milliliter at 4 years. What we found was that 98.7% of patients that achieved a PSA of 0.2 at 4 years, and we utilized 4 years because PSA bounces, benign PSA bounces, were not uncommon between 18 to 30 months. And that if at 4 years you achieve a 0.2, then the chances of you having disease-free well beyond 10 to 15 years is about 97 to 99%. And here's 98.7 at 10 years. So this is now the biochemical definition of cure for brachytherapy that is now utilized in our clinical practice. We also have some new technology that's evolved within our institution that allows for us to do intraoperative MRI. Here is a CT. We have now just submitted an abstract to demonstrate that we can eliminate this CT for all post-implant assessment. We then open up the doors. This takes you straight to an MRI, and this table docks on to the MRI that allows us to get immediate day zero MRI assessment. And so when the patient, if the patient doesn't have a good quality implant or needs intraoperative optimization, we can place the individual seeds to optimize the implant before the patient wakes up. And when the patient wakes up from the procedure, the patient doesn't have a catheter, the patient's implant is optimized, and then the patient is able to be discharged that same day with no catheter and able to maintain continence with erectile function. So this is now, I think, a very exciting development within our institution, because previously we had to wake the patient up, then send them to the MRI. And then once we got that information, if we needed to optimize that implant, we had to take that patient back to the operating room. This further optimized the workflow. And then this is what a patient what we will see. I'll see intraoperatively immediately. I'm able to put the hydrogel spacer there if I need to. And I currently have been placing that there just to help minimize that dose on the anterior rectal wall. And you can see here, this patient is getting a very high quality implant. I know before the patient leaves, I can see the rectum and the sagittal. I can see their bladder, making sure that there's no seeds inadvertently placed in the bladder. I can see the full external urethral sphincter. And here is the full distribution. And so when the patient wakes up, they know they've received a high quality implant. Here is the MRI workflow. The workflow extends from the dominant lesion. We can then identify these under MRI imaging for diagnostic workup. Everything is done in a pre-planned fashion, because what I want to be able to do is carry out the plan in which has been created, but we have intraoperative optimization so that in the event that there's changes inside the operating room, or it's not a high quality implant, or it needs to be optimized, but this is the entire workflow. So in this second line is the plan. The fourth line represents what's been delivered. This is what we call the Mars LDR workflow. And we have some early outcomes. This is right off the press. This is our early outcomes following local salvage treatment with Mars for MRI visible post-surgical bed recurrences and focal intraprostatic recurrences. We looked at 31 patients with the mean age of 71 years. The PSA at salvage was 3.3. And then the prior local therapy consisted of radical prostatectomy and external beam in 4 patients, external beam in 24 or 77% of patients, and definitive brachytherapy in 3 or 10 patients. Here's an example of one patient that had a recurrence following a prostatectomy, and this was a salvage following external beam radiation. You can see here the hydrogel displacing the rectum from the recurrent lesion. Fiducials were placed here to better localize, and then here was the focal treatment following recurrence and radiation. So this is a reirradiation case specifically. Here you can see the overall survival curve for these particular patients, and for out to 4 years. When we look at grade 2 and higher gastrointestinal cumulative incidence, you can see that rate is low with very little grade 2 rectal bleeding. For grade 2 and higher genitourinary, we had some patients that actually had grade 2 and higher, and of course grade 2 is Flomax. Many of our patients, we have about 35% that still needed to maintain themselves on Flomax following that procedure. Here's an example of some late GU and late GI toxicity. We had actually 2 grade 4 rectourethral fistulas. And this one of this was a whole gland. This one was focal. And the lesson learned from this was that when you place hydrogel into these patients who have had prior radiation therapy, the biggest concern is not the radiation dose to the anterior rectal wall. It is the potential pressure on the perirectal vasculature. And what we found was we had a case of an immediate necrosis within a few weeks due to the pressure of the spacer materials down on the anterior rectal wall. And so that gave us a better understanding of what to consider in patients that have had prior radiation and then need salvage therapy. And I can talk more about that later. If we look at the grade 2 and higher GU toxicity, you can see higher risks for patients that have focal high risk for patients that have whole gland versus focal. And then the rest was relatively non-significant differences. We also looked at patients, this has just come out and been approved from our safety and early outcomes of proton therapy and low dose rate brachytherapy boost in patients with prostate cancer. And this is utilizing MRI at every step of that process. Here you can see we have about 100 patients that got trimodality, or for high risk prostate cancer patients using proton therapy and then using the Mars implant boost. You can see that the median age is 68 years, 78% of these patients are Caucasian, 12% African American, and then you can see Hispanic, Asian, and others. The risk stratification for these patients in terms of high risk and very high risk. And then you can see the PSA of these patients. We had about 9% of patients over 20, 42% over between 10 and 20, and about half of these patients less than 10. The Gleason score of these patients, you can see in terms of 4+4 and 4+5, roughly 48% of those patients, with about half of the patients, or about 20% of patients 3+4, another 29% 4+3. And you can see the percentage biopsy cores at 41%, or between 25 and 60%. Here, in terms of the characteristics, 92% of patients had ADT, and 63% were high and very high risk. You had 26 patients that were unfavorable intermediate risk. We are implanting and doing trimodality on many of those patients as well. And then the favorable patients was about 2 patients. You can see the length of duration of ADT varied depending on the risk category. Proton therapy dose for these patients was primarily 44 gray and 22 fractions. You can see that's become more of our standard. And the pelvic nodal radiation occurred in 23 of these patients. And so pelvic nodal radiation typically does not occur in patients that have favorable intermediate risk, but in unfavorable and very high risk patients, those are the patients that we're focusing utilizing proton therapy. Passive versus scanning beam. Again, the scanning beam patients are required for pelvic nodal radiation. And then you can see most of these patients were treated with palladium at 96%. Here are the characteristics of the values and medians of the dose. And you can just see the rectum V100 is 0. So that was pretty standard. And then we monitor the external urethral sphincter, aiming to keep those median values below 0.04. Here are the patients that had time to biochemical failure. There were 3 of them out of the 100 patients. So most of these patients did extremely well. And here are some examples of when these patients who had unfavorable, very high, and a high risk recurring in terms of biochemical failure in 23, 60, and 114 months, respectively. Characteristics for late GU adverse events. You can see we had no grade 4 or 5 late GU adverse events or GU adverse events in this group of patients. So in conclusion, MARS focal brachytherapy is safe and effective for salvage treatment. Protons and MARS brachytherapy as part of trimodality is safe and effective for high risk, and MRI should be used at every step of the quality assurance process. Thank you for your attention.